Hello, everybody. I'm Don Berwick. I'm President Emeritus and Senior Fellow at the Institute for Healthcare Improvement. And it's my pleasure and privilege to welcome you to this Australasia Forum. All of us, my colleagues at the BMJ and IHI, and I'm sure all of you wish that we were doing this in person. It's such a pleasure to get together on a global scale and share our experiences, our lessons, and our enthusiasm for improving healthcare. Of course, the pandemic has prevented this, as it has last year. All of us are looking forward to getting together again in future years. I personally believe that the globalization of the quality improvement movement in healthcare is essential to its thriving and to the joy that it brings to all of us. So I look forward to seeing you in person. For now, this is the way we'll connect. My topic today is to explore how the COVID pandemic has changed the enterprise of improvement. Like all things COVID right now, that's a work in progress. I don't know how it will have changed improvement when we finally get the chance to look back on this difficult era. But I'll make some guesses and share with you my thoughts. And I look forward to questions and answers with you, and really through the year, exploring further our shared experiences in the pandemic. Some time ago, already a year and a half ago, I wrote a paper which I called Choices for the New Normal. At that time, I was asked to comment on sort of the same question: what would we be like emerging from the pandemic? None of us knew at the time how long that trajectory would be, and of course, we don't know yet when it will end. But I speculated on some of the challenges and opportunities that the pandemic was bringing us that actually would give us choices to make that we had not had before. That is, that the experience of the pandemic was giving us in the improvement movement some choices for the future, as it would for healthcare as a whole. In that paper, I selected 6 categories of choices, changes that the pandemic was bringing us. And I'm going to use that as the backbone framework for now thinking 18 months later about what we've learned and where we might head in the future. The categories that I talked about then and will now are changes in the speed at which we can learn and change healthcare, changes in our attitudes towards standardization and adherence to science in healthcare, changes in the modalities we have to deal with each other and to help each other, especially the introduction of virtual care, new awareness, new problems, new challenges in protecting the workforce, preparedness itself, where we have a lot of lessons yet to learn, and then probably the biggest topic of all, the wages of inequity and what to do about it. So let's start with the speed of learning and change. Even 18 months ago, we were watching changes occur in healthcare that we never thought could proceed at the pace they did. I served on the editorial board of the Journal of the American Medical Association, for example, where typically a paper would take perhaps several months to review and decide on and publish. By the time the pandemic hit, that journal was turning around papers in hours from submission to publication if they seemed urgent and important. We learned that we could develop standards for care faster than we ever thought. I served on a committee at the National Academy of Medicine producing reports on lessons learned from COVID. And that committee, normally in that context, would take a year and a half to produce reports. 1 month, 30 days after that committee was established, 11 pedigreed reports on various aspects of the COVID pandemic were issued. We could move a lot faster than we ever thought before. You saw that around the world. In the UK, for example, the establishment of the Nightingale hospitals. These were large intensive care unit capable settings, conversion of the Excel Conference Center in London from a conference center to a 2,000 bed intensive care unit facility in just under 3 weeks. We can move really fast. And in the world of improvement, that speed is bringing us more and more several challenges we didn't know we would have to face. And now we do, connected to the improvement movement. Probably the most important of these has to do with the relationship between speed of evolution of knowledge and the preservation of public trust. We have a public that wants to trust us around the world in healthcare, but when they watch us learn and change almost day by day, if not week by week, our standards for using masks, our understanding of the value of remdesivir, the use of dexamethasone, the ways in which we're understanding vaccines and how they work. It's difficult to keep the public with us. And we in the improvement movement haven't quite faced this challenge before of how you bring along a public that's watching knowledge evolve without losing faith in the generation of knowledge itself. For the improvement movement, we have to match the tempo of our PDSA cycles, our ability to learn, with the tempo of that change, not falling behind, but staying with it. So we can use improvement methodologies as fast as the world is pitching us new approaches. How would we use improvement in the vaccine world as vaccines and their use change literally week to week? And with respect to preserving the public trust, I think this is a very apt and important enterprise for the improvement movement. How could we co-produce public understanding and trust the same way that we're learning in the improvement movement, thanks to Paul Batalin and others, how to co-produce healthcare itself? Trust is not something created by one party and handed to another. It's a dyadic process in which partnership with the public matters. That's not a problem I dealt with before as a practitioner of improvement in healthcare, but we need to learn a lot more about our publics and how to keep our public with us. If not, we end up in disarray. This, as of just a few days ago, is the map of my country, the United States, with respect to vaccine coverage, from very low coverage to very high coverage. And what you see here is sectional differences that are absolutely dramatic. Look at the southeast of the United States, where vaccine coverage is 30% or less, compared to, say, the Northeast or the Pacific Northwest, where vaccine coverage now is approaching or exceeding 70%. That division of effort and trust in vaccines reflects in part variation in political leadership and the voices of people who ought to be helping us understand the science. But it also reflects an inability to establish connections with the public around the evolution of trust. Since, as we'll explore later, we are highly interdependent in our vaccine coverage, not just within a country, but around the world, this is not sustainable. And we in the improvement movement, I think, need to have a whole branch of work evolving over time now as increasing our skills and knowledge about how to bring the public along. The second category is related to the first. The first was speed of change. The second was the embrace of standardization. This has been an edgy problem in healthcare improvement for all the decades that I've worked on it. In healthcare, we value autonomy. The clinicians want to be able to do it their own way. And there's been a lot of tension between those who would like to standardize processes and procedures to the extent it's wise to do so, which is essential in the world of improvement, and those who really are guarding the gates so that clinicians and professionals in healthcare can do really what they wish. The answer, of course, lies somewhere in between, and the wise response to this pursuit of standardization is to standardize whatever should be standardized sensibly to create the energy, the extra resources, so that we can customize then to every single individual in the hands of every single practitioner. That's a very difficult walk. The solution is PDSA. It's Plan, Do, Study, Act. It's being able to take our changes, try to create standardization around them through serial processes in which we learn every step of the way. This is just a short list of the things that we're learning about right now. Vaccine distribution, supply chain management, how to get shots in arms. That involves constant process innovation, eventually arriving at standards, but right now in a very dynamic learning process. Policies toward masking and masking practices. We are learning as we go about the social distancing and masking and their effect, and how to introduce those into populations. What is the proper approach to testing? Even as the testing technologies themselves evolve, soon we'll have home-based testing. How will we introduce that into a new set of standards for proper management in the pandemic? Details of how the public applies those standards. We have federated systems in which there may be central governments or central authorities, but then every single locality has to decide how it will take on the standards that are being developed. And very importantly right now, as schools open in my country, how will we deal with the COVID pandemic in the context of the needs of kids to be together and in education? This is just a short list of the challenges that COVID is bringing us, all of which are susceptible, if we wish to use the sciences of improvement, susceptible to PDSA thinking. Unfortunately, a lot of these issues become quickly politicized and doctrinal, in which it becomes difficult to be the real-time experimenters that we need to be. But we know in the improvement world that trying and learning, plan, do, study, act, is a very powerful tool for figuring out how to solve these problems and others. And as we dealt with public understanding of rapidly changing science, we have to help the public understand and accept the developing knowledge over time. Why were the restaurants closed and now open? Why were we keeping kids apart and now they're together? How can we understand whether I should be tested or not? All this is not just developing policy and practice on the professional side of the table, but also the co-production of understanding with a public that can get easily confused. The third change that I talked about is the movement toward virtual care. I call this reconsidering proximity. In our training for centuries in the world of care, we have learned that getting together, the appointment, the visit, the consultation, coming to the surgery is part of the normal care process. Now it isn't. We have unlearned the need for proximity in a very exciting way as we now are moving into the era of virtual care, care at a distance, self-care, home-based care. Tremendous changes underway that bring us opportunities and challenges in the improvement movement. I guess the most significant and obvious one is to find the right balance. How do we apportion the care that we're giving and receiving in our communities between the virtual world and the need for visits? That is a very important topic for continual evolution and design, and I would look in our improvement literature over the years ahead for very interesting explorations and reports on how to balance the virtual world of interaction with the in-person world. We don't understand the finances of that. Quality improvement science can help in finance. We can understand how best to support the balance of virtual and in-person care that we wish, and to study the financial implications of what we do. Will virtual care turn out to be additional to the care that we would have had anyway, which could create tremendous financial problems? Or is there a way to look at innovation and substitution productively? That's a quality improvement question. And then quality itself. What is the nature of a good virtual encounter, by phone or by video? What is a great virtual encounter look like, and what are defects that can surface in virtual care? We're only just at the beginning of understanding that frontier, and quality improvement science can help a ton. We are, as for all things COVID, on a moving platform. This is the use of virtual care in my state, in the United States, Massachusetts, between February of the outbreak of the pandemic and a year and a half later. In-person care plummeted in my state and throughout the United States, and then rebounded. And now we're entering an era of a new stabilization, and we don't quite know where that will be or how that will be stratified among kinds of telehealth. For example, it's looking in at least in Massachusetts, and I think in the United States as a whole, that behavioral health care, psychiatric care, may stay largely virtual as not just a substitute, but perhaps an improvement on access and efficiency and quality of care, whereas other forms of encounters will be rebounding closer to the prior normal in terms of telehealth. We have a lot to learn, and we're learning on a moving platform. Notice that when the platform's moving like this, it's an ideal terrain for quality improvement. Formalist trials always have a role, but when the world is changing so fast, you need to learn fast. And so the plan, do, study, act capacities, the capacities to use the model for improvement to try things out in real time, is crucial when the world is changing this fast. A fourth area of concern is preparedness itself. This is more macro than micro, but it does have organization level implications as well. We need in the improvement movement to get involved in processes of preparedness to understand what they look like. Right now, we're not very good at it. There were many predictive models sponsored by multinational organizations and by expert groups in advance of the pandemic, which rated, for example, nations in terms of their preparedness. Those indices of preparedness turned out not to correlate very well with the success nation by nation in controlling the pandemic, reducing hospitalizations and deaths, for example. We don't have a robust model yet of what preparedness looks like. Models are developing, and we can, if we are smart as a world and within nations, find highly successful examples of preparedness systems, and we need to learn about them. This is a massive challenge for quality improvement because this involves process designs that we in the quality improvement world ought to be very ready to deal with and try. One thing we have learned is that preparedness, much like virtual care, is a dynamic process. It isn't a fixed property. Over time, as new challenges reach us, say in the pandemic in the form of variations in the virus, mutants, the arrival of the Delta strain, and who knows, future strains. Preparedness for one is not the same as preparedness for the other. Preparedness for vaccine skepticism is not the same as preparedness when that doesn't exist. And so the ability, again, to make improvements over time as the Earth is shifting, that's an important asset that quality improvement can bring to this world. Another very important one is that we now deeply understand that in the pandemic world, and I would say probably other 21st century threats, there's a whole new demand for public-private interactions. There are handoffs of materials, information, standards, practices between the public sector and the private sector that occur in every nation. And this relationship development between public and private sectors is absolutely crucial. How can we get financing aligned so that the private systems, the non-public systems, can participate fully in preparedness? How can we improve supply chains, which are not by any means totally embedded within the healthcare system itself? What relationships can be improved so supplies improve? And then very important is to be able to think about regional responses, not just organizational responses. In the United States, we have several prototype systems in Nebraska, in Massachusetts, trying to develop regional response capabilities. These turn out to be essential for pandemics and other 21st century threats. We have to think way outside our organizations in order to be able to respond appropriately. Organizational preparedness is only really a rather small piece of regional and population level preparedness. Again, tremendous opportunity for the improvement movement to participate. The next and crucial topic, the fifth of six, had to do with protecting the workforce. At the time I wrote that first paper on choices for the new normal, we were becoming aware of conceptualizing the workforce differently from before, much more capaciously. The workforce, we came quickly to realize, includes a lot more than doctors and nurses and pharmacists. It's all the people that make healthcare possible, the infrastructure that keeps us at work, the people that clean the rooms, of course, and serve the food, the people that drive the vans, even people who assure the integrity of the food supply to our vulnerable patients. So we learned and need to keep learning a new view of what the health workforce means. That involves, by the way, very close relationships with our understandings of social determinants of health. Now, 18 months later, there are other themes that have surfaced that I think are crucial to the improvement movement and to the improvement of care. The first that occurs to me is the importance of behavioral health support and psychological supports for the healthcare workforce. I should have known this, but I didn't know it at the beginning of the pandemic. Our doctors and nurses and pharmacists and people working in the healthcare system are subjected to enormous psychological stress. I think that occurs even in normal times. It's especially true in a pandemic, especially true with multiple waves of outbreaks of the pandemic as people just say, oh no, here we go again. And so we've learned a lot in the world of improvement about what proper psychological and behavioral support looks like in systems. We have some wonderful examples of such supports that have surfaced. For example, in the Institute for Healthcare Improvement's Leadership Alliance of about 50 organizations that work on the triple aim together, we've discovered innovations for reaching out to the workforce for support. One of the most important themes there is to stop the belief that the answer to successful healthcare is some form of heroism or martyrdom. We're just people in healthcare, and our institutions need to learn how to help people who are in psychological trouble, and not to regard stress or depression or traumatic stress disorders as weakness. On the contrary, we need to develop in both the young and existing workforce the concept that asking for help, reaching for help is a form of strength, and we need healthcare organizations that understand that and meet that need where it exists. That relates to a whole new theme, which I'm going to take a minute or two on, which has to do with burnout itself, the idea of becoming exhausted in healthcare. Here, we have learned a ton. Even before the pandemic, we now know that levels of burnout measured by standardized instruments like the Maslach burnout scale are extremely high. Look at healthcare burnout levels for physicians and nurses, 38, 44% prior to the pandemic. We have a workforce that really needs help. And compared to the population at large, physicians and other clinicians have much higher levels of stress and support and needs for support than the population as a whole. Now, of course, there are many other disciplines, many other subsets of the population that need help with burnout, but we're in a very stress-ridden profession, we who reach out to people in distress and try to help them. And if we don't help ourselves, we can't help them. As Maureen Bisignano has told me for years, you cannot give what you do not have. And so I think the pandemic has really stressed the importance in the improvement world of focusing on support, psychological and supports to the workforce as they deal with the stresses of being the healthcare workforce. That has, of course, increased in the pandemic. 64% of U.S. physicians say that burnout is worse since COVID-19 arrived. And the consequences, we know. I'm going to credit two colleagues of mine that I deeply admire, Steve Swenson at Mayo Clinic and Tate Shanafelt at Stanford now. Steve and Tate, I think, are the leaders in research in this field. And if you haven't read their book from Mayo Clinic Strategies to Reduce Burnout, you really should. They point out that the effects of stress and burnout in the professional population are really enormous, both on the personal and the professional side, and they have consequences for patients. As people become highly stressed, it's more and more difficult to have the professional persona. People leave their jobs, staff turnover, which is a tremendous stress for quality, goes up, patient satisfaction goes down, and medical errors go up in a population of clinicians who are experiencing burnout. So this is an absolutely key challenge for we in the improvement movement. I think we need to take it on. The Institute for Healthcare Improvement has done that. Back in the day when Derek Feely was a CEO, he began to address attention to this. And today, Kate Armate is carrying that banner strongly, as we all are. We have tremendous scientific resources. I mentioned the Swenson and Shanafelt book, which I think should be mandatory reading for us interested in supporting the workforce. And in the United States, the National Academy of Medicine produced a very fine report taking action against clinician burnout. So we have improvement's always better when we're starting with a deck of cards that's full in terms of ideas, change ideas. It's a change package. These are the two scholars who I think have contributed perhaps the most, Dr. Steve Swenson and Dr. Tate Shanafelt, and their work is well worth your studying, as along with the work of others. Shanafelt and Swenson have developed actually a framework for action, giving us ideas about what to do. And I won't review all of their work, but they regard what they call agency, coherence, and camaraderie as process-susceptible changes in an organization that can be supported to help people get through stresses like the pandemic. Agency is the capacity of individuals or teams to act independently, not as robots or cogs, but as thinking, caring, imaginative people. Coherence is the sense that we're in this together, we're united in our efforts. And camaraderie are those set of social supports and capacities in organizations that allow people to be together, to feel like a team, to work together well. I'll mention that Janefelt and Swenson have actually done quite a bit of empirical work on leadership behaviors that actually support the workforce to get through the stress of the pandemic and others. Their behaviors that they have studied, dimensionalized, studied quantitatively, include these: inclusiveness, keeping people informed, constantly getting information from the people you lead, constant support for development and recognition through appreciation and gratitude. And what they find are that behaviors like that in organizations result in much lower levels of burnout and much higher levels of fulfillment. Even one single point on their scale of these 5 behaviors results in an increase, 1 point change, 11% increase in fulfillment and a 7% decrease in burnout. They've done empirical work to support this, and these are the results in their Mayo Clinic trial with 11,000 staff, showing extraordinary improvements. If we in the quality improvement movement pick this up, not just in the context of a pandemic, but in the context of standard work, we can help a workforce do the work it really needs to do. And I say the pandemic has brought the quality improvement movement face to face with the need to support staff as essential to its excellence. You cannot give what you do not have. The last topic I'll cover may be the most important of all, and that is inequity. All of you know that the pandemic has underlined forcefully the wages of inequality, including racism and othering in society in terms of health and outcomes. That happens both within nations and among nations. It divides us as a world between the nations that are struggling with resources, the low resource nations of the world, and the rich ones. They present us with tremendous decisions we're going to have to make as a planet on our view of mutual responsibility. They raise the stakes on the mechanisms we have to work together on a global scale, the role of the World Health Organization, United Nations, and other multinational efforts. And for us in the quality improvement movement, it elevates the question of process design for the system of pandemic response. I'd say the system of response to all major threats. For each of us as individuals, and each of you listening today, I suppose this feels very foreign. How could I, as an individual, affect the global system of pandemic response? Step by step, piece by piece, by asking how you can help, and by supporting leaders, especially political leaders, who will commit to the kind of solidarity that we know is needed to keep pandemic response as a system. Within nations, the consequence of not doing that are dire. This is the American track record as of January of this year, 2021, in terms of death rates from COVID-19, comparing racial groups in my country. We are a country with a strong history of racism, and that plays out in disadvantage and threats to health and well-being, and absolutely played out in the COVID pandemic. This is an embarrassment, and it's unacceptable. And COVID has now forced us to address equity once again as a major threat to the kind of world we want to be. You'll be hearing a lot about that in this forum, I'm sure. Dr. Kate Armate has been leading IHI more and more thoroughly into the eradication of disparities in the United States and in other countries. This is a process issue. Just as we can name other problems in care delivery, like patient safety or reliability of care or patient-centeredness, we can and we need to put closing disparities in health status at the center of the agenda of the improvement movement, a lesson from COVID. That's not where we are right now. This is a New York Times article from early in the pandemic in which compared the availability of protective equipment at 2 hospitals not a mile or 2 apart in New York City. A rich one, Mount Sinai Health System, enlisting private planes from Warren Buffett's company to fly N95 masks in from China. At the same time, University Hospital, just in the same city, close by, publicly funded, underfunded, serving a safety net population, had to start employees there started a GoFundMe page in order to raise supports. We tolerate a level of inequity in a wealthy nation that's got to stop. And I think this is needs to become central to the improvement movement in my country, and it applies globally. This is up-to-date data from the World Health Organization on vaccine use, in which the wealthy countries are preserving vaccines for themselves, while the low-income countries are shuddering under the wages of the COVID pandemic. As of the day I'm recording this, I believe vaccine coverage in the low-income countries of the world is about 1.5% to 2%. We've got to stop this. I think the improvement movement needs to engage the issue of global equity, north-south equity, rich-poor equity in access to healthcare, not just in the pandemic, but for the rest of our lives. If we can't solve this problem, we're not yet the world we wish to be. How can quality improvement address global inequality as a central concern for the movement? The consequences of not doing that are not just immoral, they're unsafe. COVID binds us together in a very literal way, as outbreaks in low-income countries nurture new mutants that will reach the high-income countries. And so if all we were is self-interested, we would want to solve inequity in the pandemic context. But the same applies for inequity overall. The threats to health and well-being in countries that have less are threats to the health and well-being of all countries, both psychologically, morally, spiritually, and physically. It's time for the improvement movement to engage global equity as a key issue with every resource it has. This is George Washington's famous farewell address in the United States, in which he warns about factionalism, about otherness, about the tolerance of differences in a world where we need to learn to deal together with the problems we face. My chief mentor, Tom Nolan, who sadly died a couple of years ago, taught me so much. He taught me more than any other colleague I think I've ever had. Tom and his colleagues and associates at Process Improvement produced the Improvement Guide, which I think is now ought to be the number one resource for learning about improvement. The Improvement Guide has in it a series of change concepts, they call them. There are 70 or so in the appendix of the Improvement Guide, Appendix A. It's an invaluable resource. If you've not looked at this resource and actually looked at that appendix, you're denying yourself access to a real guidance document about how to improve. What are some general change concepts that help improvement occur? In that book, there are several. I picked out two here that focus on what I think is the most important change concept at all. In Nolan and his co-authors' words, one change concept, number 20 on their list, is consider people to be in the same system. We around the world in the pandemic struggle are in the same system. We're not in different systems. There are no boundaries high enough to allow you to think of yourself as isolated. That involves disciplines within a hospital, organizations in a city. It involves a nation that is in disarray. It involves a world that's in disarray. We are in the same system. And until we do that, we see ourselves that way, we won't be able to work together the way we need to beat this pandemic and future threats. And then develop alliances and cooperative relationships that make these real. I mentioned earlier the importance of regional approaches to the pandemic, and I include now worldwide approaches. To try to improve on your own when the threats are so interdependent is folly. We can only do this together. In the words of Ben Franklin, famous in my country as the documents that founded the United States were formed, Franklin warned, we must indeed all hang together, stick together, or most assuredly we shall all hang separately. That is the key improvement lesson of the pandemic. Everything else I've said may be important, but this is most important. The pandemic is teaching us the biggest improvement lesson of all, which in my view is this: if we cannot find ways to work with each other across boundaries, across high boundaries, across legacy divisions, if we cannot find ways to work with each other and celebrate those connections instead of lament them or fight them, then I'll tell you, our species is doomed, because pandemics are not the only threat that require us to remember how interconnected we are. The century ahead has climate change as probably a bigger threat And there is no way on this planet that we're going to be able to cope with the consequences of climate change separately. It has to be done together. Similarly, the threats to species now, the protection of biodiversity, the honor we need to give to the array that nature has handed us, or the eradication of poverty, the doing away finally of unnecessary cruelty in the planet as people are forced to be hungry or without water or shelter, and the use of conflict as the worst possible way to solve our problems. This is what threatens us for real. So yes, we in the improvement movement, we need to continue to learn to improve healthcare locally, stop pressure ulcers, stop avoidable infections, empower patients in hospitals, standardize care to the best known science, make sure that we're doing for every patient what every patient needs. But doesn't the pandemic tell us we need to do that for the planet as well? Don't we need to find a way to elevate our sights so that we in the improvement movement improve everything across the world? If we don't learn to do that, we are not going to make it. The most important change concept of all in the world of improvement that we ought to welcome and celebrate together is that we do it together, cooperation, which I think is the lesson of the forum. We are here together with a single-minded commitment to help people who are in distress, and now I'd say to help a planet in distress. Thank you very much for the chance to share these thoughts with you. I hope you have a wonderful time at this virtual forum, and we'll have an even better time when we're finally able to get together once again in person. Thank you.